Good afternoon, everyone, and welcome to today's Recovery to Practice webinar titled Using the Cultural Formulation Interview to Support Recovery. My name is Chaku Mathai, and I'm your guest host today. After some housekeeping information and a short overview of Recovery to Practice, we'll begin today's presentation. On behalf of SAMHSA, the Substance Abuse Mental Health Services Administration, and the Recovery to Practice team, we're pleased to welcome you today and thank you for joining us on today's webinar. We have, I'll get my webcam started. We have about over 100 people registered already and attending so far. We expect that number to grow. Welcome from, it looks like, from all over the country. I'd also like to thank our presenters, Roberto Luis Fernandez and Oscar Jimenez Solomon, for sharing their knowledge and experience with us today. At the bottom of your screen, you will see a Download Materials Here box, where you can download our presenters' bios as well as a PDF of presentation slides. At the end of the session, you'll also be able to download a certificate of attendance you can use for applying your continuing education credits and specifically for your professional association. This webinar has also been pre-approved for continuing education hours from NADAC, the Addiction Professionals Association. To qualify for these continuing education hours, you must attend the full webinar, complete a brief quiz, and the webinar evaluation. More information on this at the end of today's webinar. At the completion of our webinar today, an opportunity to provide feedback will also automatically open up on your browser and on your screen. Please take a few minutes to provide us with your feedback. And finally, if you have registered for the webinar, you will be emailed a link to view the archived recording. This link will also be available on the Recovery to Practice website, where you'll also find links to past Recovery to Practice webinars. This webinar has been hosted by the SAMHSA's Recovery to Practice initiative. The overarching goal of this initiative is to improve the knowledge and ability of the behavioral health workforce to use recovery-oriented practices every day. But what do we mean by recovery-oriented practices? In 2011, SAMHSA released this working definition of recovery and a set of guiding principles that incorporate aspects of recovery from both substance abuse and mental health conditions. Some of you may recall that many of us who are people in mental health and addiction recovery were brought together in order to build this working definition of recovery. SAMHSA's working definition of recovery is a process of change through which individuals improve our health and wellness, live a self-directed life, and strive to reach our full potential. The 10 principles of recovery shown in this slide, along with the 4 major dimensions of recovery, home, health, purpose, and community, form a solid foundation for developing recovery-oriented lives and for building recovery-oriented services and systems necessary to support them. SAMHSA's Recovery to Practice initiatives helps you turn these principles into workforce practices. The Recovery to Practice curriculum was developed by discipline-based curricula format by actual discipline associations. The goal was to promote understanding and uptake of the recovery principles and practices. Developed by the 6 professional associations for educating their membership about recovery and behavioral health, these materials are adaptable for use by other disciplines and organizations seeking resources to build a recovery-oriented workforce. Links to these curricula are available at SAMHSA's Recovery to Practice website. Recovery to Practice is expanding its discipline focus to embrace multidisciplinary services and integrated settings. Those of us who work in behavioral health or in integrated healthcare organizations have opportunities every day to promote recovery and wellness. We can powerfully communicate hope for recovery and the value of self-care and wellness just in how we approach our work. Recovery to Practice can help you strengthen your recovery-oriented practice through the free webinars, newsletters, and conference-based educational events. This webinar is going to be focused on introducing participants to the Cultural Formulation Interview, an evidence-based tool used to guide practitioners in understanding the worldviews of people seeking services. I'm very excited now to introduce you to our speakers for today. Dr. Roberto Luis Fernandez is a professor of psychiatry at Columbia University Medical Center and Director for the New York State Center of Excellence for Cultural Competence and Hispanic Treatment Program of New York State Psychiatric Institute. Dr. Luis Fernandez's research focuses on developing clinical interventions and novel service delivery approaches to help overcome disparities in the care of underserved cultural groups. His work centers on improving treatment engagement and retention in mental health and physical health care by persons with anxiety, depression, schizophrenia, and other serious mental illnesses. He also studies the way culture affects individual experiences of mental disorder and their help-seeking expectations, including how to explore this cultural variation during the psychiatric evaluation. He led the development of the DSM-5 cultural formulation interview. Oscar Jimenez Solomon is a senior staff associate in the Department of Psychiatry at Columbia University Medical Center and research coordinator of the New York State Center of Excellence for Cultural Competence at the New York State Psychiatric Institute. Mr. Jimenez Solomon was born and raised in Peru. His research focuses on consumer empowerment in the areas of culture, language access, and financial wellness. He is currently the principal investigator of a project funded by the National Alliance on Mental Illness, NAMI Star Center, to develop empowerment videos and tools for youth experiencing first episode psychosis and their families, and he is a board member of the American Society for Hispanic Psychiatry. It is my pleasure to introduce them both to you all, and Roberto, you may now begin.
Roberto, I believe you're on mute.
Sorry about that. I think you have seen my mouth move and nothing come out. My phone was still on mute. My apologies. Good afternoon. It's great to be here despite the technical problems. And I'm very excited to be talking about the cultural formulation interview. Now, this next slide will tell you about the overview of what we are going to discuss today. We're going to be focusing on the importance of paying attention to the culture of the person and the family, as well as the community of the person, in the process of helping that person recover from a mental health condition. As the overview shows, first we're going to talk about briefly what we mean by culture, then the importance of doing a cultural assessment when the person comes in for care. We're going to spend a few minutes on the development of the CFI that Chaco mentioned, this evidence-based interview for assessing the role that culture plays in how the problem is interpreted of the person and how help is understood and sought. And the CFI was included in the DSM-5, which is the latest revision of the American Psychiatric Association's Diagnostic Manual of Mental Health Conditions, so it is being used across the U.S. and internationally. The next part of what we're going to talk about is briefly on the content of a cultural formulation interview. And then, very briefly, we will review the results of an international field trial that examined the CFI as part of the development process of the DSM-5. We obtained feedback from hundreds of patients and dozens of clinicians and relatives to finalize the cultural formulation interview. At that point, we will switch presenters, and Oscar Jimenez Solomon will review the way the CFI promotes the SAMHSA recovery principles and present the stories of 3 young people living with mental health conditions and how the use of the CFI was helpful in their care. And we'll end with a question and answer period that Chaco will moderate. First then, let's get on the same page about what culture is, or at least how it is assessed using the CFI. In the process of creating the CFI, we defined culture as the process of meaning making that the person and the person's social network, their nearest and dearest, their family, friends, and others in their community, this process of meaning making that people go through in order to make sense of what is going on in their life. It's an ongoing process of meaning making that what makes that process cultural as opposed to only individual is that this meaning making is influenced by our participation in specific social groups, because we belong to many social groups that affects how we think, and that collective influence is what, on our recreation of meaning, is what we consider culture. These social groups that can influence how we think and feel can be very varied. They could be due to age. It could be an age cohort that influences us, a gender identity, a sexual orientation, language, race, ethnicity, national origin, a faith community, even a profession. Firemen and veterans and policemen think about their mental health conditions partly by virtue of being firemen and policemen and veterans. So everybody has a cultural background that influences them, and by that fact, then, we don't just intend the CFI to be used by ethnic or racial or sexual minorities. Everybody has a cultural background that affects their views. And in DSM-5, as you see on the slide, in the introduction to the CFI, what we did was list these three components or ways of defining culture that you have on the screen. First, we describe the process of meaning making as affecting values, orientations, knowledge, and practices that individuals use to understand their experiences. Then we talked about the aspects of the person's background themselves that affect their experience and the social context in which they happen that can affect how they feel and understand and experience mental health conditions. And then, very specifically, we wanted to emphasize the role of the immediate social network of the person, which often means their friends and family, because this is some of the groups of people that most influence how we think. This slide is up because I wanted to explain how it's not as easy as just asking the person, in order to do a cultural assessment, it's not as easy as asking the person, well, tell me how your culture influences you. Because we are often unaware of many of the influences that affect how we think. And they're very unconscious sometimes, or simply out of our awareness. And so it's important during a cultural assessment to talk with the person about how they understand the situation, how they define it, what's going on, how do their community, friends, family to help them understand it, what do they think is going on, what should be done about it. And because of these questions, we have multiple, it isn't a single question in an assessment, it's multiple questions to try to get at the person's point of view. And another element of culture that's very important to notice at this time is that it isn't monolithic, it isn't single, the influence. We have many influences that affect how we think and feel at any given time, and they can vary in importance, rise and fall in importance, either over time or for a particular setting or a particular situation. So this is the way in which culture affects us continually in a changing way. It's dynamic, and we're all mixes of cultural backgrounds, what we call hybrid. We have a cultural background that is hybrid, and therefore it's important to ask the person directly about a particular situation that they're in and a particular problem that they're defining. We don't necessarily define what's going on with us and discuss it in the same way when we talk to our priest, minister, imam, than when we talk with the primary care physician or when we talk with the employment counselor. It also changes over time. As I mentioned, it's dynamic, so it's important to keep that in mind as we see changes in the cultural understanding as the person goes through the situation, the problem, the illness. And this all means the fact that much of culture is not immediately obvious, the fact that it changes, the fact that we have many influences, each of us behind us. It means that we can't just assume by looking at a person what they're going to say is the most important aspect of their background or identity that affects how they feel. We have to ask directly, and this is exactly what the CFI does. Now, this next slide reminds us how there are so many ways in which culture affects us, especially when we look for ways of getting through, living with a mental health condition, improving from a mental health condition. It affects everything in the way that we react to our mental health conditions, for example, how we identify them, whether we see them as an illness or as a problem or as something else, the kind of help we seek, our expectations about that kind of help, what we expect about our level of participation, attendance, what recovery means to us. So there are so many ways in which cultural background and identity affects how we think about the situation when we're going through it. And also, as providers, culture also affects how we think of a situation. Whether we define it as an illness or something else as providers, which illness we define it as, how we communicate with the person seeking help, how we support the individuals, our communication styles, our priorities that structure our work settings. In so many ways, these are affected by culture, including our moral stance towards care. Now we're going to take a few minutes and go through a poll to ask you a question and get your feedback on what, in your opinion, which of the following is the best way to learn about the cultural context of a person seeking services. And if you don't mind clicking on those bullets, and I will, I think we can all see how people are answering, but I'll comment on it briefly as we move forward. Apparently, a fair number of people, over half, think it's very good to talk with the person about the cultural understanding directly. That goes along with the idea of the CFI. Other people feel, a substantial minority feel, that it's important to let it come up naturally in the discussion. That's also something that could happen. The one possibility about that is that it happens more naturally. Another possibility, though, is that it is not covered, as may happen in some settings. So most people who are answering, and many of you answered, I appreciate that, feel that it's important to ask the person to discuss the culture, which is very much in keeping with how we think of the cultural formulation. Now, in terms of what a cultural formulation, in terms of what a cultural assessment should be, this was items that we kept in mind in defining the cultural formulation interview, because a cultural assessment, should be comprehensive in the sense that it accounts for all the relevant cultural factors that are involved. It should be thorough in that it explores these factors in sufficient depth. It should be standardized in that it can be reproduced in different settings and populations, this assessment. It should be skills-based in that the competency in discussing the person's situation is not based on a shared background, but rather shared on a set of skills that the interviewer has in discussing these issues. It should be person-centered in that it starts with the individual, not the clinician's assumptions about the group he or she thinks the person belongs to. And it should be educational in the sense that it identifies gaps in cultural competence going forward that can be filled with information that you do as you do many more of these CFIs. So in developing the cultural formulation interview in DSM-5, which I will tell you about in a minute or so, I'm going to inform you of the content of the CFI. I'm giving you here the background of how we developed it. We first started content-wise with this outline for cultural formulation that was in DSM-4. That was the preceding edition of the DSM, the Diagnostic and Statistical Manual, which DSM-4 was in 1994, and it included these topics in a narrative framework of what a cultural assessment should consist of. And for example, these are the 5 here. There should be a cultural explanation, cultural identity should come first, and it's the person identifying what aspects of their cultural background are the most salient to understand their presentation. That would go first. Then second was cultural explanations of illness, which essentially are the person's views of the mental health condition and care are tapped in that section. Then the third section is on cultural factors related psychosocial environment and levels of functioning. So we want to understand the person's context and how that affects and creates sometimes the predicaments that the person is in. And then the fourth section, it's important to discuss how the person seeking help and the person attempting to provide help, how they are relating to each other and how their different styles of communication might be helping or not helping the encounter. And then there's a fifth section that puts it all together and tries to make it relevant for the person's care. That's what we started from for DSM-5. We started from a narrative description, but what we did in order to improve the CFI is to go through a series of developmental process, which I will go through in a minute. But first, here is a slide that tells you where you can find the CFI. When you download the slides, you will get these web links, And the great thing is the American Psychiatric Association has made these interviews available. They're all components of the CFI, which I'll explain in a minute. They've made it all available to you free of charge on the APA website, and these are the links. So that's great in terms of dissemination. This is the development process for creating the cultural formulation interview for DSM-5. We reviewed the outline for cultural formulation, the narrative framework I just discussed, and all the research that has been done about it, and all the ways in which people all around the world had already tried to develop interviews based on the outline for cultural formulation. They were involved in the development. We first created a briefer, slightly different version, and we tested that in an international field trial that also included this training approach that we used during the field trial, but we did it in 6 countries and 11 sites with over 300 patients and 75 clinicians, and a fair number of relatives in some countries also came in and provided input. We analyzed those results, and we revised the final core version of the CFI into a 16-question version. That is what we're going to discuss now in a minute. And we have been in the process of sharing the results of that field trial ever since. This is the content of the cultural formulation interview. The cultural formulation interview has 3 components. They are the 2 round components in the middle and the square component on the right. First is the core CFI, is what we call a basic assessment that can be used with any patient in any setting by any provider. Any person seeking help, in fact, doesn't have to be a patient or in a medical setting or identify as a patient. Anybody seeking help can be helped, we think, we hope, by these 16 questions that we'll go through in a minute. That's the basic assessment that gives a basic understanding of their cultural background. But sometimes we want collateral information, and that's where the informant version comes in. It asks the same 16 questions about the person, but from somebody else, their wife, their mother, their daughter, or father, or brother, or whatever. And then there is the third component, which are supplementary modules. If you want more information on any of the domains of the core or informant CFI, this can be used as an adjunct in assessment. Right. Usually we recommend it at the beginning of the encounter. So it's a way of getting the person's story and starting with the person's biggest interests and importance of their views right off the bat before going to what the clinician or the provider thinks is important. This is what the cultural formulation interview looks like on the page of DSM-5. This is the core formulation. You can see it has 2 columns. One for guiding the interviewer in the content of what the question is trying to get at, and then the questions on the right. And as you will see, there are introductions to the person seeking care to explain what the purpose of the interview is. There are probes in case that we need to ask more, we need to get more information, the question hasn't been clear, like that. There are several ways in which we try to elicit the material organized into 4 domains, which I will cover now. The first domain of the CFI, of the core CFI, is how does the person understand what's going on? And we call it in the CFI the problem. And in most of the CFI, there is a bracket of the CFI that says problem in caps. And these 3 questions here, which try to get at how the person and the family and friends understand what's going on, is what the provider uses going forward in terms of clarifying what the person sees as the problem. For example, if the person defines the problem as feeling full, as somebody did in one of our training tapes, I just feel full. That's how they describe being depressed, suicidal, and so on. They just can't take it anymore. We use that phrase of feeling full as we go forward. So these questions ask about how does the person define the situation? How do they describe it to their social network as a way of getting at more of how they feel about it? And what is it that troubles them the most about the situation? The second domain has to do with what the person, what is the context and the understandings of cause that the person has. And there's a section also on the role of cultural identity. And we go through these 3 different types of items, 3 subdomains. Causes, both from the view of the person and the social network. What is it about the context of the situation that makes it better or worse? And then, again, the definition of background or identity. We describe it to the person, very similar to how I described it at the beginning of the presentation, as something that everybody has, that many different social groups. We describe all of that to the person. And then we ask the person, what is the most important aspect of your background or identity? And then we ask, how does that background or identity affect the current condition? It could be good or worse. It could be for good or to make things worse. And any other concerns the person has regarding cultural identity. For example, if they haven't brought it up yet, if they feel discriminated in some way, for example, this could be a place to bring it up. Here is the third domain. What are the cultural factors that affect how the person has coped in the past about it? There are the ways they've coped about it themselves on their own, the help they've sought, and what kind of help was most helpful and not helpful. And we ask about all kinds of help, spiritual help and any kind of help, to make sure that we cover everything the person can do. And then what are some of the barriers to obtaining the help? And we give examples of the barriers. So here's another poll. Have you ever experienced a misunderstanding between practitioners and persons using services due to differences in cultural backgrounds, identities, experiences, or expectations? And you can see the options on your screen, and people are starting to answer. And we can see that people sometimes is the biggest response, or often is the second most common response, have had this kind of experience. So this question that I'm about to get to in a minute about misunderstandings in current help seeking is an important aspect of the cultural formulation. The last element of the cultural formulation has to do with current help seeking. And we ask the person, what is it they need now? What kind of help? And it has two parts. What are the preferences for care? What do they think is most useful at this time? And then the second one is, what else does the social network think would be useful for you at this time? And the last question relates to that question about misunderstandings, because sometimes it says sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different expectations. And we ask the person then, have you ever been concerned about this? And is there anything that we can do to provide you with the care you need? And the purpose of this question is the idea that we want to make sure to give an option to the conversation there about acknowledging that the provider also is present, also has a culture, and there may be things going on in the relationship that are worthy of note in terms of cultural issues, may come up now, a person may answer now, or may come up in the future. Now, I'm going to skip the field trial in the interest of time, just tell you that we did it all over the world, and essentially it was found to be very feasible, acceptable, and useful, especially by patients. And as people did it more and many more times, as a provider did it more than once, they found it even more feasible. So at this point, I'm going to turn it over to my colleague, Oscar Jimenez-Solomon, to do the second part of the presentation.
Thank you, Roberto. Good afternoon, everyone. Before I get started, I'd like to thank Recovery to Practice team and SAMHSA for the invitation to talk to all of you about this important topic. During the time I have with you, my hope is to share my perspective on how the cultural formulation interview can support the recovery process and outcomes of individuals in very specific ways, and offers a concrete tool to help behavioral health services and professionals to develop recovery-oriented practices in the areas of assessment, treatment planning, and shared decision-making. When I first heard about the cultural formulation interview about 3 years ago, I was very excited. And 3 years later, I can tell you that I am even more excited as I see and I learn more about its potential and its opportunities. And I'd like to tell you why, especially from a recovery-oriented perspective. My research and work focuses on developing effective ways to empower individuals in recovery. I'm particularly concerned about how recovery supports and peer services can help address the cultural and socioeconomic context in which people seeking services or people in recovery live, work, etc. Because this context can create opportunities for individuals, but also limit their capability to recover. In my opinion, behavioral health services in the United States and the Western world have been historically unable to address cultural topics and other contextual factors in very effective ways. Mainstream services have been a lot more comfortable working with individuals and at times with the implicit notion or assumption that individuals are necessarily or always capable of changing their conditions. It seems like a very core value in our Western culture. But we know that recovery does not occur in a vacuum, and that the stigma, discrimination, racism, homophobia, xenophobia, and socioeconomic injustices that many individuals experience affect their ability to recover. So behavioral health services and professionals must find ways to support individuals to address these structural factors, lessen their impact, and also figure out ways that organizations, communities can address these effectively and address specifically the social and cultural forces that limit the opportunities of individuals and families. During the first part of the presentation, Dr. Luis Fernandez commented on how the CFI came to be in and its main domains, questions, and some of the research behind it. What I'd like to do in this section is to do first a walkthrough through some of SAMHSA's recovery principles and give you some examples on the ways that the CFI framework and the CFI questions can help providers and services to put those principles in practice. We won't be able to go over all the 10 principles, but we have prepared a handout that you can download at the end of the presentation or at this moment. So, as you know, many of you, SAMHSA has been working for many years on a definition of recovery and principles to help guide the efforts of improving behavioral health services. My first example is on principle number 2. One of the most important principles, the recovery is person-driven. Empowerment, self-direction, and self-determination to choose recovery and supports. Recovery services and supports are the hallmark of this principle. So as you've heard from Dr. Luis Fernandez, questions 1, 2, and 3 of the CFI ask individuals to articulate in their own words, what their main concerns are. What concerns many of us about dealing with a behavioral health challenge is usually, though, the way our challenges affect the things that we care about. For example, medication side effects might bother us for the side effects, not for the side effects themselves, but also because of how they impact our relationships, our ability to work, our ability to go to school. Another example I can think of is staying out of the hospital or from illegal substances might be important to us because otherwise we might lose the job that we've worked so hard to get or ruin our efforts to get our children back. In short, these questions seem to ask, these questions that I'm referring to, questions 1, 2, and 3, ask individuals to talk about what matters most to them. This is important because we know that without hope and personal motivation, recovery seems very unlikely. Second example is that the CFI also supports the recovery principles, this recovery principle by making explicit the perspective of the individual about what is happening to them and why this is happening, which is the focus of question number 4 of the CFI. Behavioral health disciplines often explain what someone is going through from a biomedical or psychological perspective, while people in recovery usually talk about their concerns, what's causing their concerns from their personal experiences and context. What a clinician, for example, is a medication compliance issue for a person in recovery may not be having, not having enough money for a copay or time to refill a script. To a practitioner, an individual may be failing at employment because of lacking of coping skills or poor job readiness. But for a person in recovery, maybe the fact that he's working as a custodian when he was promised to be helped to get a job in his field. Another example is that having an open conversation about these potentially different perspectives is essential because they might help us understand that the solutions we have for a problem may also be different. Without the explicit understanding of what an individual feels, without the explicit understanding of what an individual feels, it may just not be possible for him to truly participate in the decision-making process. Another example is around recovery principle number 4. I'll just mention this. Question number 11, where we ask individual about the things that the individual may have done on his or her own to deal with their concern. Usually this is an entry point to hear from individuals about the importance of faith or spirituality, for example, natural supports, self-help, peer support, and many other personal strategies. In question number 13 of the CFI, we ask about barriers that may be hindering the opportunities of an individual to recover. This, for instance, can help us assess the importance of financial barriers, other structural barriers such as discrimination, racism, homophobia, immigration status. And it will help us contextualize what might simply look like individual beliefs or idiosyncrasies, and recognize the role that organizations, neighborhoods, communities, and policies have in the recovery process of individuals. Moving on to the next example. In example and principle number 6, the CFI offers, in our perspective, practitioners with concrete questions to explore the role that the social network of an individual is playing and can play in his or her own recovery process. They may be one of the most important innovations of the CFI. Specifically, question number 5 prompts a conversation of how members of the social network see what is happening to the individual. This is important because an individual may feel that their family, friends, organizations, or others in the community see what's happening in ways that are either helpful or unhelpful. Knowing this seems like really important to develop strategies to manage those differences, build allies, and develop advocates, and advocate for their support. Jumping to principle number 7. Hopefully by now we have some good ideas about how the CFI can help practitioners and individuals to recognize that recovery happens in the context of culture, social relationships, and other social dynamics. But when we talk about, like Dr. Luis Fernandez was saying a bit earlier, talk about culture, we're not only talking about the culture of the individual and the family, but also about the culture and this culturally constructed views and expectations and assumptions of practitioners. And this question, in my perspective, question number 16 that Dr. Luis Fernandez was highlighting, really prompts individuals and practitioners to talk about how cultural differences or dynamics between individual and practitioner may shape their partnership and therapeutic alliance. And in my opinion, this is in itself a transformative question because it not only helps potentially improve the communication between practitioners and people receiving services, but in fact may actually shift the actual dynamic and power dynamic between a provider and a person receiving services. And finally, I'd like to comment very briefly on principle number 8. This is the last example, and we know that trauma orientation is really important to our work and recovery. And question number 13 explicitly asks us to consider the role that structural factors may be playing as barriers to recovery. And this seems important and is important because it might help us understand that there are external forces in the context in which people make recovery efforts. And recognizing this context helps us to move from thinking of the onset of behavioral health challenges as solely individual results of individual processes to a more contextualized processes. And in many cases might actually help us to respond to traumatic circumstances or experiences that may in fact be the most adaptive responses. Might actually help us to avoid blaming the victim or the psychiatrization of poverty or pathologizing what we simply don't understand. The last few minutes, I would like to talk to you about the stories of 3 individuals, 3 scenarios. I will comment particularly one of them, that I really hope that can help illustrate how this standardized tool can help practitioners and individuals have conversations about some of these issues and address barriers to recovery that can get in the way of individuals. So for the first story is the story of Ranki. Ranki is a 19-year-old West African woman who, in the process of the CFI, we discovered that she considers herself an artist. She loves clothes and designing clothes, but most importantly, she considers herself a woman of faith. What matters most to Ranki is her faith, and excuse me for a second. And what really bothers her most is the way that taking medications has been blocking her from finding her purpose, and that every time that she has had difficult feelings or others around her think that it is a sign of mental illness. In fact, she actually sees what she's been experiencing as a spiritual experience and is not ready to tell her provider how she really sees things. Ranki feels she was really happy, elated, connected to God, just dancing, and others interpreted this as a psychotic break. And most important of all, the last time that she told a clinician what she really thought and what she really felt, she felt shamed, patronized, and invalidated when she was told that she was not having a spiritual experience, that she was in denial. This is an important point because we must recognize that when whatever is happening in the room may not be just a result of what's happening in the room, but in a sense of a result of a person's experiences and those of the clinician. Was this some form of racism or prejudice, or was this simply, from the perspective of the clinician, an objective clinical judgment or observation? We don't know for sure, but what we do know is that Ranki is experiencing, what Ranki experienced is prompting her to feel distrust, and that her clinician might have to work even harder to gain her trust and insight into her cultural formulation. So moving to the last part of Ranki's story, like we were saying earlier, what matters most to Ranki is her faith. She also loves clothes and designing clothes, and one day she would like to become a naturalist and not have to depend on chemicals. When her clinician first tried to engage Ranki, though, to understand what mattered most to her, how she saw what was happening, how the clinician could help, Ranki met her with distrust. And in time, Ranki and the clinician started to develop trust. And probably the most pivotal moment in their relationship was when her clinician not only did not try to convince Ranki that she was not having a spiritual experience, but actually asked her, have you thought, embracing her framework and her cultural formulation, asked her, have you thought about what your God-given purpose is? How can I help you fulfill her purpose? So the lesson from Ranki's story is that she did not need to be convinced that she was mentally ill to remain engaged and thrive. Her provider and Ranki have still, to this day, some different perspectives on what happened to her. In her case, it was not a deal breaker, the fact that they had different perspectives. But still, Ranki knows this and still sees that the provider stay in the relationship with her and has allowed her to trust the clinician with difficult feelings of sadness, loneliness, and memories of painful experiences. 2 years later, Ranki is pursuing her goal of going back to college, and she's well. Hopefully this example has given you an idea of a practical application of the cultural formulation interview. You will see, we're not out of time, but you will see two other examples in the PowerPoint. that will give you a better sense of how this can be applied and some of the lessons to the process of recovery and engagement that hopefully the CFI can actually offer to all of you. So at this point, I'd like to actually turn it back to Dr. Luis Fernandez.
Thank you, Oscar. We're only going to spend a couple more minutes and discuss some training possibilities and then a concluding slide. The training possibilities is that we're very excited about the fact that there is a web-based one-hour training on the CFI, the core CFI in particular, that is going to be coming out next month, we expect. We're on track for that. And it's going to be initially available free of charge in New York State, and we are in the process of we're very excited about the possibility of obtaining permission to have it more accessible to more nationally and even internationally. There will be CME and CEU credits for the New York State folks, and again, we're working on the process of making this available more widely. It includes a discussion by 5 people about their own experience. We're very proud to be able to say that these are people who are living with mental illness and who have very generously contributed their stories as a way of training other people. They're involved, many of them, in the recovery movement, in the, say, for example, peer specialist training, and they're hoping that their experiences can help guide other people through this difficult experience. Many of them are recalling in the videos even how they felt and as if they were back in the past at a time earlier in their recovery process. So hopefully that will come out very soon. Now this is the last slide, which summarizes basically some of what we've discussed. We feel that the DSM-5 cultural formulation interview promotes recovery principles, that it can be used with every person seeking help for a mental illness or mental health condition in any setting by any provider, that it was developed to be person-centered to avoid stereotyping and elicit the person's point of view as well as that of the social networks, that it is implementable and operationalized, and that it can guide clinical assessment and treatment negotiation following a shared decision-making approach. Now, many of these things have been evidence-based in the sense that we developed them in an evidence way, like the field trial, for example, but many of these outcomes, how the CFI can actually help people to show that it does that, we're now in the process of conducting research. So I'm going to stop there, and I'm going to turn it over to Chaku, and we're very happy to discuss and answer any questions.
All right. Thank you, Roberto and Oscar. Great presentation. And there are a couple questions that we want to present from the audience and continue the conversation. So first of all, the first question that came in was, has the CFI been validated with refugee populations in the United States?
The answer is not exactly, no. Most of the data that we have on the cultural formulation interview comes from the field trial. And the field trial had certain settings in the U.S. where they, they did work with clients, with patient populations across the country. You didn't get a chance to look at the map for very long, but there are people in New York, New Haven, Minneapolis, and on the West Coast in California. Some of those sites could have refugees among their patients, but there wasn't a single site where they were all refugees. On the other hand, in the Netherlands, your question was about the United States, in the Netherlands, at least one of the sites had a refugee base. So it was used with refugee by people who specialize in the care of refugees. But more research could be done in this area.
Okay. Thank you.
Sure.
Second question is, what types of challenges and successes have you seen utilizing the tool with interpretation services or interpreters?
Again, an excellent question, and a question for which, this is like a whole, we're hoping a whole career of research for some of my junior colleagues, in that there's much work left to be done. I know that in the field trial, we excluded people who needed interpreters because we wanted, in order to test the CFI originally, we wanted people who, the patient and the clinician and the relative sometimes, could communicate in the same language. So there was everybody spoke the same language when they came into the room. However, there were many languages. So there's like 12 or 15 languages all over the world because you know, in California, there was not only Mandarin and Cantonese, there was Tagalog, and there was several languages in India, you know, so there were many languages involved, but they weren't through the interpreter. And that's something that we're very interested in. How could you use the CFI with an interpreter? And something that, again, requires more research.
Got it. Okay, thank you. So another question that came in earlier in the presentation was about how the conversation about culture, if you remember your poll, is introduced. And, you know, what have you learned about the best ways for this cultural assessment or cultural formulation interview to be introduced? Is it now we're going to talk about your culture? Is it would you like to be? And what's your take on how that's done?
Yeah, no, these are great questions. The way we conceived of the CFI, and it's a bit of a conceit, if you will, an arrogance, is that we are hoping that people will start their usual interview using the CFI. So in fact, it's not like we have, okay, we've done all this thing we should do, and now we're going to do this politically correct thing called the CFI, let me introduce it. The way we thought of it is that people would start with the introduction that we have at the beginning of the CFI, which is a very standard introduction, but it adds the issue of culture. And it says something like, this is our suggested language, I would like to understand the problems that bring you here so that I can help you more effectively. I want to know about your experience and ideas, etc. So it's very person-centered. There are no right and wrong answers. It's very person-centered, but that's how you would start from the beginning. And then you keep going with what brings you to the clinic, how do you understand it, how do you explain it to your social network. Basically it substitutes for the usual way of starting, and we feel that a lot of the information that you would get in a regular evaluation, you would get through this. And then after you, and you have a question at one point, I imagine, about how long this takes. In the field trial, it took over 20 minutes, 22 minutes overall. So it's a big chunk of the first interview. It's about half to a third. But we hope, and we're trying to show in research, that if you spend that time getting the person's story first, of course you can spend more time, you know, we're not telling you to stop. You can spend more time getting the person's story, but if you at least spend 20 minutes doing that, you're more likely to get a rapport, an engagement, an understanding, participation, commitment from everybody. That's our hope.
Thank you. Oscar, did you have anything to add?
No, I was actually looking at some of the other questions. I wasn't sure that are coming up. I was actually curious about the question on the use of the CFI in a peer context. I wasn't sure.
Oh, go ahead. Let's talk about it. That's certainly one of the questions we had, and it's being raised by the audience as well. So how can this be used, or has it been used in peer-operated or family-run organizations?
Yeah, that's a great question. You know, we didn't have time to go over this particular story, but I'll just mention this very briefly. Actually, this is one particular instance that I can actually comment on. Maybe you look at it, the PowerPoint with more detail, where the cultural formulation interview was used with Mike in the context of peer support, where the practitioner was actually the peer support provider, and actually this is Mike online, actually with a peer support provider online. And where the focus of their work was actually to help Mike to be able to have conversation with his father about what he really wants to pursue, which is to go back to school, although that is word for him, and that is maybe being a little overprotective, and some also gender role expectations are coming up about what is a good job for young men. And but ultimately, through the relationship with the peer support provider, what it's become clear to Mike is that he doesn't have to choose between him and his career or his recovery goal like his father, but actually that he can actually, with support, have this difficult, courageous conversation with his father and bring him on board. Maybe. Roberto, you can comment a little bit more, but I'm not aware that this has actually been tested in terms of research in peer contexts.
Not yet, but we're very happy to work towards that.
Yeah, and also one of the in the video, the online module that Roberto was actually referring to earlier, one of the scenarios is actually happened in the context of a peer-supported employment setting. which is actually this young man, Nicholas, who is actually his main concern or quote-unquote problem is that he doesn't have a job and he wants to work. That's his problem. He doesn't have money. and really the interaction with the peer provider is, peer support person is to help him understand, okay, what's happening and what he can do and how work is important in the context of his identity as a young man and also as a Caribbean man. So that's what we can share about that.
Okay, thank you. So there's a number of questions that are moving towards implementation in various settings, whether it's addiction recovery coaching, peer-run services, re-entry support programs for those of us who might have been involved in criminal justice systems and settings. One of the, kind of bottom line questions that's come up is it your feeling that all presenting problems have an underlying cultural involvement and thus require culturally based intervention? And Roberto, you mentioned defining culture as meaning making, and that there's this meaning making process that you're either both understanding and engaging about how a person perceives what they're going through. So I'd love to hear both of you or either of you responding to that, and then how that leads into work in future settings.
I'll take a quick stab, Oscar, and then I'll shut up. Yes, my position is that every experience is culturally based of any kind, not just illness or problem or concern, but every experience. We make meaning in the context of culture. There is no such thing as life without it, outside of it. So we're always in some social group. We're always in many, many social groups. We inherit culture, we recreate culture, we pass it on to our children. It's a process of making sense. So yes, everything, in my opinion, requires asking the person, what sense do they make of what is going on? We call that cultural, because we don't stop at just the idiosyncratic idea the person may have, but we connect that idea with whatever background or identity they have. That because we find it useful. That is, I guess, my short answer.
That's yeah. Oscar?
Definitely a yes. Definitely a yes. And maybe the perspective that I might add to what Roberto was sharing is just more something that, in that way, maybe reiterating something that I said during my piece is the part of what the CFI captures that is contextual too, right? That is what's happening in the room that is not happening in the room necessarily, right? Or what we all bring from the outside. I mean, in a sense, really what's happening in an interaction is a little bit of a microcosm, right, of the society at large, right? And we all bring our expectations about each other and the way that we express it and the way that we seek help, it's just there's no way that can escape that. And from that perspective, I would add to this the notion of culture, those kind of bigger things that are harder for us to talk about, like racism and stigma, discrimination, and other things that are really big forces that we can't avoid when we're sitting in the room and that shape what expectations we have of each other and our practitioners and also our ability to recover. So
not only that, but everything structural is also related to cultural values and ideas. The fact that we have certain number of minutes to talk to people in certain settings. This is all a sense of, it comes from a sense of what's important.
Well, this is certainly a great start to this conversation that is certainly, as you said, not over. There's lots to learn from each other as we move forward with it. I certainly feel that this is not only a transforming tool and variable to be entering into the work, but it's revolutionary. It's something that all of you have been working towards for some time. There's a number of questions that are continuing. Unfortunately, we're out of time. So what I'm going to encourage you to do, if you're in the audience and have additional questions, reach out to the Recovery to Practice Initiative. Reach out to Dr. Luis Fernandez and Oscar Jimenez Solomon. You can see their information at the contact slide here below. And Also, you can email directly to RTP as well. So as we move forward in this process, I want to give you a reminder that if you are interested in NADAC continuing education hours, please click on the NADAC link where you'll be directed. I think you'll see some additional emails here. I'm going to move ahead to the NADAC information here. You'll be directed to a page with an evaluation and a quiz to complete to receive your certificate. If you're not interested in receiving NADAC's continuing education hours, you may download a certificate of participation as well as the presentation slides in the download materials here box, again, as we noted at the beginning of the presentation. Please also complete the feedback survey that will automatically load directly following this webinar. I'm going to go back one slide and just encourage you to check out the webinars that are in development. There's a 3-webinar series that's coming up on shared decision making, and as Roberto noted earlier, that this is something that is an important part of the process of incorporating the information you receive in a cultural formulation interview, as well as a Learn More webinar on psychiatric advance directives. So please join us for as many as you can. And remember, if you can't join us, all of these webinars are recorded and made available online at the Recovery to Practice website. So on behalf of SAMHSA, I'd like to thank all of you for joining us. I'd like to, especially for taking the time out of your day to attend today's webinar. We appreciate your interest. We also thank Roberto and Oscar for all the time you've taken in presenting with us. On behalf of the Recovery to Practice team and everyone at SAMHSA, thank you and good afternoon.
Good day.